Hey, Vet Rehabbers! Thanks for joining us. I've got Amie Hesbach, and she is going to be chatting to me today about neurology cases for hydrotherapists. Thanks, Amie, for joining me.
Thank you for having me, Megan.
Amie, we're really excited to having you do some lectures for us at Vet Rehab Summit. So you're obviously going to be doing two lectures on the hydrotherapy day, which is on the 15th of November, and also on the 16th for the Small platform. That's about obesity.
Yeah, I'm very excited. Actually, it gave me an opportunity to be somewhat introspective on what I do in neuro rehab and how neuro rehab has really evolved over the past years. So it's a very exciting area.
Amy, I'm just going to read your topics for the hydrotherapy day. So it's the influence of aquatic treatment environments on neuromuscular tone, and then swimming to walking. So very, very cool topics. And I really like the swimming to walking one because that's always a question, that a lot of clients have. We're teaching our dogs to swim. Is that going to actually teach them to walk again? So yeah, looking forward to the topics. And I know that you've done a lot of research looking at new research that's come out in the human field as well as the animal field.
Absolutely. Yeah, it is. It's a very exciting area of research and one that we're looking at on the human side of medicine and rehabilitation as well as on the animal side. And it's interesting to see how the different modalities and approaches come back around and are utilized in combination and separately, and the different outcomes that we're getting. The hope that we're having for spinal cord research and treatment, both for humans and animals.
So, I mean, when we're looking at hydrotherapy for these neurological cases, there's always this question. So, do we do swimming or do we do underwater treadmill? So, for those of us that have got both a pool and an underwater treadmill, we can use both. But a lot of us maybe just have one or the other. So, we've either got a pool or an underwater treadmill. Do you have a preference for neurological cases as to which type of hydrotherapy, or do you think that we can use both of them equally in these kind of cases?
I do think that we can both use both equally. It is a bit of a luxury to have both at our disposal, and we can pick and choose based on the specific criteria of and characteristics of the patient. If I had to choose one, I would probably choose an underwater treadmill. Not just for the efficiency of treatment, but for the ability to manipulate the variables of the treatment fairly quickly. Really with that swimming to walking and deep pain negative treatment of spinal cord injury, being able to utilize the different senses that are provided by the water and by the treadmill surface, and the manipulation by the therapist as well. It's pretty amazing. It's a very dynamic therapy. I certainly think the underwater treadmill is a great dynamic tool for us, but we need to use it effectively and efficiently, not just toss the dog in and see if they sink or swim.
And how important is that proprioceptive input that they get, walking in the treadmill in comparison to when they're swimming?
Yeah, I think proprioceptive input it's really the key. It's I think super important, but we do have to think about the type of sensation that the pet is experiencing both internally from its body, from the body receptors, where those signals are going, and then also externally from the environment. If we don't have a surface by which to provide that proprioceptive input, what can we do as therapists to manipulate, to expose them to more of that input and more of those sensations? It's very patient dependent, and I think the therapist has to assess and reassess over time. Are we providing too much input, too much sensory input? Are we not providing enough? What is the water environment doing to that sensory input? How is that manipulating things? Is it better? Is it worse for the patient? There are really a lot of considerations, and really through my research, it helped me to look at things with a different perspective and through different eyes. We can look at the research, we can look at our clinical experience, we can gather information from other clinicians, and maybe even develop, I don't want to say protocols, but develop a positive direction, a standard of care really, for those spinal cord injured patients to help them to return to purposeful walking again.
So one of the questions, we often get asked, especially from clients where the patient's actually been referred quite late, so like I've had a few patients that are referred like 3 months after a spinal cord injury or incident, and they still are not ambulatory. And, I always explain to them about the ability of the spinal cord to be able to actually regenerate, and the sooner we do it, the better. What do you recommend to clients with regards to, say we're fortunate enough to get the patient straight after the incident? When do you normally start doing swimming or underwater treadmill with them? Do you have sort of a timeline that you work from, or is it really just dependent on the patient?
It is dependent on the patient, but I think we do have to consider, I guess the patient specific or diagnosis specific criteria. Putting an animal in water, whether just supported with the buoyancy of the water and the water treadmill, or supported with nearly 100% of the body weight in the pool, what is that doing biomechanically, not just neurologically to those sensory receptors, but also biomechanically to the spine? So if there was an area of the spine that is destabilized from a surgical procedure or is under some active compression, that's going to really play into how soon, how quickly, how acutely we can utilize aquatic therapy. I think, the key is do no harm. We do want the patient to improve, but we also want to see that the rehabilitation that we're providing is better than just rest, is better than just time. So it is a challenge, especially when we get those patients 3 months, 4 months, 5 months down the road, when we're the last ditch effort, honestly. And, are they going to improve at that point in time? I do like to see patients as early as possible, even on an inpatient basis, potentially. And if it's the right patient and we have the right tools at our disposal to make the patient comfortable in the water, sometimes we're getting them in, especially a giant breed dog, we're getting them in the water very quickly after surgery by just protecting the incision and, protecting the patient to just provide some of that input and get them weight bearing as quickly as possible. But some that we know have chronic instability or chronic compressions, we might wait a little bit longer just to allow things to heal, allowing that inflammation to come down initially, and provide some stabilization by the healing process first. So there's no hard and fast rule. There are definitely a lot of considerations to be made.
Yeah, I think the mindset with most vets is changing, because I remember when I was at vet school, we were taught just to cage race, then put them in a cage and don't do anything, don't let them move. And I think that's obviously changing now. But I'm sure that some of you guys that are listening still get referred those cases that have been cage raced for weeks. And then they come to us, and we've got quite a job to do, don't we?
Yes, absolutely. And those, and those patients that have been cage rested for such a long period of time, the owners don't want to touch them. They don't want to manipulate things. There's that fear that comes into play and anxiety. I think the patient picks up on that as well. And that's not doing a whole lot of good for anyone's recovery. I like to think of physical therapy and rehabilitation as being more of an active rest or kind of a more manipulated than, or like a safe rest, rather than going all out and doing full activity or doing no activity at all, finding some happy in between. And really, there are so many things that we can do early on. I appreciate that veterinarians, surgeons, and neurologists are understanding a little bit better what we do in rehabilitation and physical therapy. I think there was an understanding at one point, or a misconception maybe, that we were just going to throw the dog in the underwater treadmill, stick some electrodes on and get those muscles pumping and put them on the ball and bounce, bounce, bounce and have them walk over the cavalettis. And that was physical therapy. And, I think as they understand us and as we develop a more positive relationship and allow them to understand our knowledge and skills and experience, we're really able to demonstrate to them that some of that early physical therapy can actually be very helpful and very appropriate too. It's picking and choosing from all those tools and toys that we have and finding the right one at the right time for that patient. And that takes a lot of experience. It takes a lot of knowledge and really digging deep back down into the basic sciences. What's happening at the level of the spinal cord, what's happening with the nerves, what's happening with the muscles, what's happening within the brain, not just with the motor cortex, but also, those limbic systems and things, the fight or flight and, anxiety that may be invoked by the crate rest and by the absence of touch and isolation from the normal environment of the patient. So many different considerations. And I try to flesh some of that out in these lectures for the symposium. So.
Let's chat about those ones that are not recovering, because it's always so hard for us therapists when we have a patient and we're just not seeing any changes in them. And we're dealing with the client, and they want to know, like, when do we call it a day? And a lot of them, we hope will just say that, okay, the dog can have a wheelchair, and they'll keep the dog as a paralyzed dog. But some of them, that's not okay for them, and they have to make some hard decisions. So how do you handle those situations? Do you have sort of a time period that you say, like, over this many months, like, if we don't see improvement, then we're not likely going to? And always whenever I say that, I have my I'll say it's 3 months. Then literally like 2 days before the 3 months, we'll get one little bit of improvement, and I'll say, okay, let's give it another month, and we carry on. And I once had a dog that it was a Dachshund that after 8 months was walking. And we've just pushed it on and on. We just saw little, small incremental improvements every single month. And I said, let's just go another month. Let's just go another month. And you always have that worry. You think, well, am I wasting this owner's money and time and emotion? Because it's so hard for them. They're putting so much into rehabilitating everything that they're doing at home and what we're doing. And sometimes it doesn't work out that way.
Yeah, I agree with you. It can be so very frustrating, but also so, heartwarming and exciting when you do see those little glimmers of hope. I don't know that I have a specific date in mind. I always look at the beginning of physical therapy as being day one, and so it might be a patient that comes in the door. I was going to say walk in the door. And if they walked in the door, then my job is done. But they're coming in the door, and they might be 3 months, 4 months post-op, and nothing's happening. And the owner is keeping that in mind, and the surgeon or neurologist is thinking 3 to 4 months. I'm thinking day one. So this is the first opportunity that I've had to intervene. And But what about that patient that has been in therapy for a month, for 2 months, for 3 months, and not seeing any of that progress? This is really the opportunity to assess, to reassess. We need to be doing that all along the way, but we need to step back and try to be as objective as we possibly can. And that's hard to do. We do have some, functional scales and scores that we can utilize. And I think it's so important for us as rehab practitioners to use those objective scales from day one, because that's going to give us a number. And the owner's seeing that pet every single day, and they're not going to see those little tiny, changes or significant changes maybe over time. You might see the patient once a week, you might see them twice a week, and that's going to give you a little bit more objectivity maybe, but putting numbers on their functional status, I think, is key. Even if you have the luxury of working with another clinician who is rehab certified, having them put hands on, having them assess or reassess, come up with a new treatment plan. Unless there was a red flag or a significant concern, I'm not rushing back to, you need to be reevaluated by the neurologist. Because in a way I look at that as, throwing up my hands, I'm done, I can't do anything. I'm likely to lose the patient, in some cases. In other cases, the neurologist certainly may have some positive input, but I don't rush back to the referral source unless there's, an obvious need or a concern there. But many times I will utilize other resources. If I know a veterinarian or an acupuncturist, someone who does Chinese medicine, maybe has a different approach than my own. And, I've always been that way as a therapist, and utilizing those other resources, maybe pointing the owner in a different direction, maybe coming to a different, plan myself, trying a different strategy. I think we get into a routine a lot of times with these patients where we're doing similar therapies time after time, and sometimes just to shake it up a little bit, try some e-stim, try some laser therapy, see how they're responding differently, in the water, out of the water, with a cart, without a cart, whatever that might be. So, I have a hard time giving up as well when I see those glimmers of hope. I do know it's us against time, because I've been under those deadlines before where an owner said, you know what, we've got one more week, and we're going to make a decision. And that's a hard place to be in. That's when I really wish I had that magic wand in that toolbox. I don't. Maybe one of our modalities guys can invent one for us, and who knows where we'll be in another 5 or 10 years though too. We're really coming to an amazing place in research, and medical research, translationally too, with people and with animals. So so long story short, I don't know that we have a real answer for that one.
So you just reminded me of a case that I had. It's a little Dachshund called Milo, and the owner came to me. The dog had had cage rest for 3 weeks, and it had no deep pain, and it hadn't got a proper diagnosis. So no MRI, no x-rays, nothing. The owner was basically like 9.5 months pregnant. Like, I think she was due in a week, and they were a very young couple that didn't have a lot of money. And they came to me, and they basically had the first appointment, and they said their baby is now overdue. So like she should have had the baby already, and they can't deal with this, okay, because the dog was urinating everywhere, and obviously they'd had it for 3 weeks in the vet, and now they've taken it home, and now they were trying to make this decision when to put the dog to sleep, because this is something that they didn't feel like they could cope with. And somebody had told them about me, and they said, no, this is their last chance, and I have 1 week to make the dog walk. So it had no deep pain at all, nothing. And amazingly, I said, okay, fine, I'm going to try my best. And obviously I was a bit doubtful. I thought, well, it's got no deep pain. It hasn't done anything for 3 weeks. It's just been in a cage. the likelihood that I see any improvements in the next week is so small, but I'm going to give it a go. And we hospitalized the patient for the week. And I used acupuncture, so I used to use that a lot in these kind of cases. And I basically created a plan, and the whole team that worked at my practice, we all were in on it. So, like, we had this dog, we were doing exercises like 6 times a day on it, stimulating all the time. We got into the underwater treadmill, we tried everything. And 2 days later, the dog had deep pain. 4 days later, the dog was able to stand. And 7 days later, the dog was walking, but obviously still had some proprioceptive deficits. But she came with her big tummy, and they took the dog home after the 7 days, and they were so happy, and I was so relieved.
Wow.
So yeah, that was like one of my miracle stories. And whenever I lecture here in South Africa to vets, I always throw that one in, because I want them to see, like, this is possible. I mean, this dog didn't have an operation, we didn't have a diagnosis, I treated what I saw, and it responded so well. So yeah, it's one of my major success stories that I can remember from practicing.
That's an amazing story, and I'm sure, you know, so many of the rehab clinicians listening in have those amazing stories that they want to share. But what really strikes me with that story is that finally you have the opportunity to throw it all at the patient. You know, you have the staff, you have the modalities, you have the time, you know, and you're creating this ideal environment, this ideal rehab, you know, situation, and look at the outcome. Look how amazing that is. And, you know, so trying to convince the owner, the veterinary neurologist that this is a good idea to start this early, to do this early, would be incredible. I mean, we wouldn't have so many of these pets 3 months post, you know, with significant atrophy, you know, bladder or urinary tract infections and things. You know, we wouldn't have the bed sores and pressure sores and things like that if we could just bombard them with all we got, you know, and really make a difference early, because then we're kicking into those reflexes. We're kicking into, you know, kind of that innate ability to walk again. And it's so amazing, and it's awesome to see, you know, just the progression, and when you have that available to you, you know, and it makes a believer out of you, out of the owners, out of everyone on staff. You're like, we can do it. We know we can, you know, and somehow that dog had the right raw materials, you know, and it was the right thing at the right time. You know, I wonder if a month earlier or 2 months earlier, if you had that opportunity, would the outcome have been the same? Maybe a little bit better? Who knows? Yeah. So hard to say. Neurology is a tough one, because, you know, we don't see these nerves regenerate. We don't see the healing process. You know, we can't take an X-ray or an MRI and really see anything other than, you know, changes in inflammation or compression. And so there's that nebulous, you know, having to believe and understand, you know, even theorize, you know, what's happening and what's going on. But I do think acupuncture has a huge part in that patient that is non-responsive to traditional therapies. You know, it's opening things up, and making the body available to the therapy. You know, and I'm a believer for sure. So that's an awesome story. I love it.
Amie, the last thing I want to chat to you about is gait training, and specifically looking at human medicine in comparison to what we do. So you often see these sort of like robotic kind of devices where they walk people sort of strapped in these harnesses. You know, for us, we do a lot of gait training in the underwater treadmill. But yeah, is there a difference in what they're doing in humans to what we're doing? Are we quite far behind with gait training?
You know, I honestly don't think we're so far behind. I think, you know, I'm seeing so many of us, you know, doing gait training in the water treadmill, you know, doing gait training on a treadmill with harness support, you know, doing gait training, you know, in a cart or a wheelchair. And, you know, really the key is getting into that, that central pattern generator. You know, it's giving that sensory input to the nervous system, trying to figure out where it's going to go and what it's going to stimulate, and then what outcome can we get. You know, we do have like the exoskeleton and the robotic, you know, training and human medicine, but you know, what they're finding is that those are great interventions, but you know, using electrical stimulation, actually they're using e-stim in the spinal cord, and they're getting even better, you know, outcomes that way. You know, using some of these other modalities and finding that there needs to be some sensory input as well. So whether it's proprioceptive, whether, you know, it's using approximation, whatever it is, some weight bearing, you know, and I think we're all kind of coming to a head where we're coming to these same conclusions. I don't know that we'll ever see that robotic training with animals. I think that that's on the edge of, you know, ethically and, you know, with animal rights and you know, cruelty, abuse and all that. That's a bit of a stretch, but, you know, certainly, you know, if we're using a cart or a wheelchair, you know, assuring that the patient is positioned appropriately to, you know, stimulate those CPGs, or to get them at the right frequency and the right rate, and doing it as often as possible. I'm sure you and probably many others, you know, remember Christopher Reeve, you know, Superman, and how he went through therapy after his horseback riding accident. And it was awesome to see. I mean, he was riding a bike quite a bit and using, it was an electrical stimulation, functional e-stim bike, but he was doing it like 6-8 hours a day. I mean, this relates to your Milo story where, you know, if you have enough of the therapy, you know, frequently the duration is right, you know, maybe we're going to get that glimmer of hope. Maybe we're going to get that outcome that we're looking for. You know, Christopher Reeve didn't have a functional outcome, but he did have changes in sensation, and he had changes in muscle activation, you know, before, unfortunately, he became septic. But, you know, I think a lot of these interventions that we have, it's the right thing at the right time, and, you know, the right thing for the patient that we're seeing, you know, until we can come up with that, that standard of care, that protocol, and, you know, and utilize it across the board, I'm not sure that we'll really know. But I know those of us who do neuro rehab, I mean, it's got a special place in our hearts, you know, where we really feel for the patient and the family, and we're really invested. And a lot of times we're seeing those patients for a long term, but it's such a team approach. You know, really, it takes a lot of people, a lot of energy, a lot of time, a lot of money, unfortunately. So if we can be more efficient or effective about our therapy, then all the better. I think we're all winners, honestly.
Yeah, I mean, they are such challenging cases, but they are so rewarding. I mean, if I think back to my practice days, I can remember the first time a dog walked, that we were, you know, obviously treating. From everyone, from the person who makes the tea to the receptionist, would be like jumping with joy. Oh my gosh, like the whole team, you know,
Yeah.
so excited, you know. It really was a team effort, you know. Everyone was wanting. And we used to, especially those cases that were hospitalized, we used to have a lunch break and we didn't have any other clients. We used to put them in those adjustable wheels and let them zoom around the practice, and they'd come to us while we were having lunch, and we'd spend time with them. And so the whole team, like I say, from the receptionist to whoever's making tea, really would get involved in all those cases. But they're super rewarding.
Yeah, I do think, you know, I think the cases that I've had that have probably been the most severe that we've been able to hospitalize or board for rehab, I mean, those have probably been the most rewarding and most successful. And that's kind of interesting because you think about the environment that they're in. It's more what we call an augmented environment, where there's more interaction. You know, it's safe interaction, but there's more interaction. And how many of our owners, if they might be bringing their pet in, you know, twice a week, 3 times a week, even if they're bringing them in every day, they're not stimulating them in that home environment like they're stimulated when they're in rehab. Where your entire team, including the girl who makes the tea, they know what that pet's there for, and they know a little bit of what to do, what's safe to do to help that patient again and to encourage
Yeah.
them. And I do think it's a mindset too with the team, as well as the patient, not to put human characteristics on that pet, but that has a whole heck of a lot to do with it too. If the pet is stuck in a crate or in a cage, for hours on end, both at home and in the hospital, that can be a real downer, for sure. And that's not going to help the nervous system to recover. But if we can give them, positive feedback and, in a great environment and rewards, and let them play ball, whatever it is, even if they are in a cart, even if they are in a recumbent position, giving them some positive interaction, I think it can do a world of good for sure.
Amie, thank you so much for chatting to me today, and we are all very excited for your lectures. For those of you that are online Pet Health members, you guys get VIP access to the Hydro Day if you're a Hydro member, and that is on the 15th of November. And I think your lectures are just before lunch. Is that right, Amie?
I think so. I think that's right.
Do you remember?
So,
or maybe just after lunch? Yeah, I think you're just before lunch.
Gosh, I know. This time zone thing makes me a little bit crazy. I can only imagine how you and your staff deal with it. Yeah, I'm like, is it day? Is it night? And have we switched hours yet or not? So, but yeah, I'll be there tuning in. I'm really excited to hear some of the other lectures as well. Biomechanics and other modalities and things too. So it looks like a really dynamic, fun course.
It's going to be an awesome 3 days. Yeah, we've got 17 different lecturers in different
Wow.
time zones, like everyone. So running it is going to be hectic. Looking forward to your lectures, Amie. Thanks so much for joining me, and we'll see you in 2 weeks. Cheers,
All right,
guys.
sounds like cheers. Take care. Bye-bye.
Bye.